Good morning, one and all. I welcome the speaker, Dr. Sarat Babu, to deliver his lecture on this important topic, biomarkers to diagnose acute rejection kidney transplants. You all know acute rejection still happens to be the real problem for any transplant setting. And even though many advances have been made, still the diagnosis or prediction of it and detection identification at a very early stage remains elusive. I expect the speaker is going to update us on the recent developments on that, invasive markers and non-invasive markers for acute rejection. The floor is yours.
Thank you, sir. Good morning, all of you. At the outset, I would like to thank the organizing committee for giving me the opportunity for a talk today. The topic given to me is the biomarkers to diagnose acute rejection in kidney transplant recipients. So kidney transplantation is the best treatment modality for ESRD, leading to improvement in patients' quality and quantity of life. With significant improvements in short-term outcomes, prolonging the long-term allograft and patient survival remain the ongoing challenges. The ability to monitor allograft function and immune tolerance and predict rejection accurately would enable personalization and better prognostication during post-transplant care. The emerging biomarkers can help detect kidney allograft injury early enough to prevent permanent damage and detect injury before it is clinically apparent. So what is biomarker? Biomarker is a characteristic that can be evaluated as an indicator of normal biological process, pathological process, or pharmacological response to therapeutic intervention. This is the timeline of early and late causes of graft dysfunction that can be further divided into immunological and non-immunological. Immunological include the hyperacute rejection that comes in the immediate post-transplant period, followed by the acute rejection, which can be early acute in the first 3 months or late acute from month 3 to month 12, followed by chronic rejection. Among the non-immunological causes, the most important is the acute tubular necrosis in the first month post-transplant, followed by acute CNI toxicity that can lead on to gradual chronic CNI toxicity. Another threat is the recurrent or de novo disease post-transplant and followed by infections, which can be nosocomial, latent infections, or community-acquired infections. And last but not least is the BKV nephropathy, which can cause allograft failure. So what is the drawback of traditional biomarker? Currently, the kidney transplant we monitor through a complex of clinical, immunological, instrumental, and histological parameters. Clinical means we check the proteinuria in the urine, or creatinine we check the GFR. And the immunological means is the measurement of donor-specific antibodies. Instrumental means the presence, looking at the resistivity index in the Doppler. Histological is the biopsy we do. But all these traditional biomarkers have low sensitivity specificity, and doing a biopsy is an invasive procedure. And at the level of pathologist, there may be poor reproducibility, the intra-observer variability, and it is dependent on the expertise, and there may be a sampling error. Even at the level of nephrologist or transplant surgeon, it is not quantitative, there is no definite thresholds, and difficult prioritization in complex cases, difficult evaluation of process activity, and low prognostic capacity. So, because of these traditional biomarkers, because of all these drawbacks, there may be delay in the detection of rejection and treatment. So with the advent of new innovative biomarkers, the biomarkers have been the focus of intense research over the last decade to overcome these limits and improve allograft monitoring. A plethora of new non-invasive biomarkers measured in either urine or peripheral blood have been studied, mainly with a diagnostic and prognostic meaning. Most of them are derived from omics revolution and can be considered the cornerstone of precision medicine. So the advantages of omics biomarkers for prediction and treatment of allograft rejection. These omics technology aim primarily at universal detection of genes, that means genomics, mRNA, that means transcriptomics, the proteins means proteomics, and metabolites means metabolomics. So, with the help of genomics, prior to transplant, we can assess the pre-transplant underlying risk. Followed by the use of transcriptomics, proteomics, and metabolomics, we can identify even at the stage of subclinical rejection before it can proceed to a clinical rejection. So, early prediction and treatment of allograft rejection is possible with these biomarkers. So, how will you categorize biomarkers? These biomarkers can be categorized into 7 categories. One is a susceptibility or a risk biomarker. It estimates the risk of developing a condition like acute rejection in a stable graft without any clinical sign of dysfunction. Diagnostic biomarker identifies patients with a disease or a subset of it. Example, those who had developed acute rejection. Prognostic biomarker is the one that estimates the likelihood of clinical event or of disease progression, staging the severity of disease. The predictive biomarker estimates the likelihood of achieving a favorable response from a therapy. Example, eculizumab for complement fixing DSA. The monitoring biomarker is useful for serially measured in order to detect a change in the evolution of disease or signs of drug toxicity or to detect exposure to immunosuppressive drugs. Pharmacodynamic or response biomarker verifies that a biological response has occurred after drug exposure. Safety biomarker estimates the presence and severity of drug-related toxicity, example CNA toxicity. So these are the biomarker categories, and the novel biomarker can be further classified as immunological and non-immunological biomarkers. Immunological biomarkers characterize immune dysfunction ranging from subclinical to overt rejection. Non-immunological means they demonstrate adverse transplant outcomes whereby immune dysfunction is not the sole aberration at play. For example, delayed graft function, cardiovascular events and infections. Coming to the immunological biomarkers, the most important thing is the donor-derived cell-free DNA, dd-cfDNA. It has gained widespread utility as a biomarker in the transplant community since its introduction. dd-cfDNA are the small fragments of cell-free DNA released from the graft cells into the recipient circulation due to cell death or injury, and they have been proposed as biomarkers of acute rejection. So while dd-cfDNA represents an average of 0.34% of total cfDNA in the plasma of stable transplant recipients, levels are increased during acute rejection and to a lesser extent acute pyelonephritis and ATN. In the DART trial, higher dd-cfDNA levels in patients with acute T-cell mediated rejection, BANF more than 1B and ABMR and chronic active rejection was reported. dd-cfDNA levels not only increased before changes in serum creatinine but also decreased after rejection treatment, suggesting that longitudinal monitoring of this biomarker could be useful after a rejection episode and possibly limit the need for surveillance biopsies. This is the usefulness of dd-cfDNA. One is in the rejection and graft surveillance, where the values less than 0.5% reflect likely graft quiescence. And relationship to histology, it was levels were correlated with varying grades of ABMR and TCMR on molecular microscopy, and elevation in low-grade TCMR is associated with future EGFR decline and de novo DSA formation, and its correlation with kidney function and de novo DSA. Consistent elevation of dd-cfDNA more than 0.5% is associated with a twofold risk of 25% decline in EGFR, and elevation is associated with higher risk of future de novo DSA formation. And beyond conventional rejection, it has utilities in detection of AT1R antibody mediated rejection and BKV nephropathy, and also programmed cell death 1 inhibitor induced rejection. Next comes the urinary and serum chemokines. The interferon induced urinary CXC ligand 9 and CXC ligand 10 chemokines are associated with the T helper cell immune response and involved in T cell recruitment in inflammatory process. They are promising as biomarkers for T cell mediated rejection and ABMR. Additionally, urinary CXCR3, the receptor for CXCL9 and CXL10 expressed on activated lymphocytes, was shown to detect subclinical inflammation and correlate with the evolution towards chronic damage. Next are the leukocyte subclasses. Donor reactive memory B cells are a subset of B cell pool with emerging data support of robust response to L antigen post-transplant. Donor-specific memory CD4 T cells have also been implicated in the rejection. Through the use of genomics in combination with histological scoring, Asdani et al. Were able to derive specific immune cell types and demonstrate that the presence of NK cells is predictive of antibody-mediated rejection. Other tests are the gene expression profiles. The peripheral blood gene expression tests such as TrueGraph or K-sort, they appear accurate in identifying state of immunological quiescence in stable transplant recipients. Due to high negative predictive power, TrueGraph or K-sort could allow to rule out ongoing subclinical rejection through serial monitoring as an alternative to surveillance biopsies and guide immunosuppression minimization in fragile patients at low immunological risk. Gene expression profiles can also be derived from urine. And interestingly, an accurate prediction from two genes, proteasome 20S subunit beta 9 CXCL10 was equivalent to the 11 gene model with a high sensitivity 93.6 and specificity of 97.6%. Next in order are the cell-free microRNAs. Cell-free microRNAs are the short non-coding RNAs that play a pivotal role in regulation of gene expression through epigenetic, transcriptional and post-transcriptional mechanisms. They can be isolated, quantified and profiled by multiple platforms which can also characterize their target genes. They have been studied in graft preservation fluid and proposed as viability biomarkers. These are the potential biomarkers for acute rejection. One is a 3-gene signature CTOT04 study, where it was found that it is useful in detection of T-cell mediated rejection. The main features are it increases up to 20 days before histological diagnosis. 7-gene signature caliber study, it also increases 7 weeks before histological diagnosis and decreased after treatment. And next is the 17-gene signature GOCAR study. It identifies subclinical TCMR and correlates with long-term graft survival. Next is the 8-gene signature, which is useful in the detection of ABMR, correlates with the histological features of acute and chronic ABMR. And panel of gene signature CTOT8 study, it detects both TCMR and ABMR, correlates with clinical and histological outcomes and with de novo DSA, useful to identify immunologically quiescent patients. Next is the endothelial associated transcripts, ENDATs detect ABMR. Analysis of endothelial transcript predict ABMR with excellent accuracy. So all these biomarkers help in early detection of rejection before we could see histological changes. Other potential biomarkers are the CXCL9 and CXCL10. They are also helpful in detecting TCMR and ABMR with a high negative predictive value. Low levels at 6 months predict low risk of rejection until 24 months. Highly accurate for ABMR diagnosis when associated with donor-specific antibodies. Others are ddcfDNA, allogenic circulating B and T cell assays, and N-glycan. N-glycan levels predict rejection-free survival in kidney transplant from live donors. These are the non-immunological biomarkers. They are basically measured in the perfusate used to perfuse the graft kidney, especially in patients with donor after cardiac death, donation of the kidney after cardiac death, donation after brain death. So they have assessed the biomarker levels NGAL and LFABP, MMP2, LDH, NGAL in the perfusate of kidneys, and it was found that each doubling of perfusate NGAL and LFABP were independently associated with decreased 6-month EGFR. So highest perfusate concentration of these biomarkers were found in the DCD kidneys followed by DBD and living donor allografts. These are the other potential biomarkers for delayed graft function. One is the mitochondrial DNA in the donor plasma. The main features, it predicts delayed graft function in DCD donors, donation after cardiac death donors. Complement C5a in donor urine predicts delayed graft function. MicroRNAs in the graft preservation fluid, LDH, NGAL and MFP2. Exosomal mRNA for NGAL and NGAL, and furosemide stress test. Furosemide stress test is production of urine of less than 350 ml after a 4-hour infusion of furosemide indicates the occurrence of delayed graft function. Other potential biomarkers include the microRNAs 182 5p, microRNA 21 3p, 146A 5p. All these things in the recipient serum and urine and recipient peripheral blood and renal tissue with features that help in predicting onset of delayed graft function. Another important tool is the extracellular vesicles. Extracellular vesicles is a general term that includes membrane structures of different size released by cells after fusion of endosomes with the plasma membrane called exosomes, or shed from the plasma membrane called microvesicles. So these extracellular vesicles are taken up by the neighboring or distant target cells, paracrine or endocrine effect, and mediate a wide range of physiological and pathological processes including renal disease. EVs also exert pleomorphic immunomodulatory roles in kidney transplant. Their bioactive cargo includes graft antigens, co-stimulatory or inhibitory molecules, cytokines, growth factors, and functional microRNAs that modulate the expression of recipient cell target genes. Therefore, potential application of plasma and urinary EVs as biomarkers in kidney transplant have been studied. So, here these are the EVs as potential biomarkers of delayed graft function, and EVs as potential biomarkers of acute rejection. Here you have plasma C4D plus, CD144 plus, and endothelial EVs. They predict ABMR. The levels correlate with ABMR presence and severity and decrease after successful treatment. Next is the plasma endothelial EVs. Predict ABMR combination score based on 4 mRNA transcripts overexpressed in EVs of patients with ABMR predicts imminent rejection in HLA sensitized patients. The levels increase in ABMR, decrease after treatment in early post-transplant. However, they are also influenced by renal function recovery. All these are plasma endothelial EVs. Next is the urinary EVs. They predict the TCMR. A total of 11 protein enriched in urinary EV in patients with TCMR, total of 17 protein enriched in urinary EV in patients with TCMR, and high levels of CD3 positive EVs released by T cell in urine are strongly associated with T cell mediated rejection. Other potential biomarkers are the non-HLA DSA. Non-HLA DSA include the antibodies against type 1 receptor for angiotensin II and endothelin type A receptor are the most studied non-HLA activating antibodies and appear to exert their effect either alone or in synergy with DSA. Anti-vimentin antibodies detected before KT, probably reflecting previous endothelial damage occurred during dialysis, have also been associated with graft dysfunction. Anti-perlicon or LG3 antibodies are highly prevalent in hypersensitized patients and have been associated with acute ABMR, delayed graft function, and reduced long-term survival. Anti-endothelial cell antibodies, which include a wide range of autoantibodies against several surface antigens, may also prove to be a source of rejection biomarkers. Finally, the development of antibodies directed against tissue-specific self-antigens such as fibronectin and collagen type 4 increase the risk of acute rejection in pancreas kidney transplantation and transplant glomerulopathy in KT. Others are the heat shock protein 90, heparan sulfate, urinary glutathione S transferase. All these things are helpful in early detection of acute rejection. To conclude, development of omics technology and expanding knowledge of new tools such as EVs, extracellular vesicles, and donor-derived cell-free DNA has led to increased availability of a wide range of new potential biomarkers. The non-invasive biomarkers measured in urine or blood appear promising in providing very early diagnosis of pathological processes. Tissue biomarkers have also proved effective in integrating traditional histology, leading to improved disease nosology and more accurate prognosis. Although larger multi-center validation studies are needed before a combination of biomarkers can be widely implemented in the clinic, a transplant physician should rise to the challenge of becoming familiar with this new landscape. Thank you.
Thank you for that nice update. But the thing is that, even though there is so much of current knowledge on all these things, ultimately it boils down to only two things that have really proved to be useful. One is the rejectose sticks, the urinary dipstick of transplant recipients, measuring the FOXP3 and perforin granzyme that came up from Manikam Sudhandaran's unit. That is one thing. The other one is that the recent hype about the donor-derived cell-free DNA. The other day also we had a lecture on that. Even a lot of caveats, even that also, but at least donor-derived cell-free DNA, it is useful for its negative predictive value of 81%. If it is less than 1%, it rules out ABMR. Rather than being an indicator of ABMR, or a diagnostic marker of ABMR, at least it rules out in a clinical setting. Beyond that, the other things are remaining just as theory. Probably let us hope that in the near future, these things may get translated into clinical practice. Any questions from the floor?
Okay. Now, how long does it take for these lab tests to arrive for us?
I am not sure about it.
Most of these remain experimental, all these omics and all that. Most of the centers, even the best of the centers don't have those facilities. Even the NDATs, which is incorporated as one of the diagnostic criteria for ABMR, I don't think it's available in most of the centers. Further questions, we'll close the session. Thank you so much for that wonderful update.
We request the chairperson to give the memento to the speaker.